Welcome to our oral scientific abstract session of this year's conference. I am Suzanne Huffnagel. I'm the chairperson of the Scholarly Activities Committee. I'm going to be running this session. The moderators include myself, Dr. Jane Huffnagel, Dr. Mario Gonzalez, and Dr. Sean Washak, who is the chairperson host of this conference. This session is going to showcase 10 abstracts. We're going to start with scientific investigations and end up with complex cases. These 10 abstracts are going to be scored by we, the moderators, and we're going to be giving a certain score. And you, as the audience, are going to participate as well. And how you do that is when you open the mobile app and you go and you'll see the little sessions program. If you scroll down, you can see where it says scoring abstracts. Last year it was an app, but this year it's the QR code there. And you click on that says scoring the abstracts. You'll get 3 questions that you have to answer. It's going to be after each of the abstracts. And if you do that, then all your scores are going to be tabulated. And then they're going to go into who gets the top 2 awards, one in complex cases and one in scientific investigations. So you have a chance to help determine the fate of our presenters. The presentations are going to be 7 minutes long, a maximum of 7 minutes long, hopefully, and then that leaves 3 minutes for questions either by the audience, or if there's no audience questions, then the moderators will ask some questions. We are really excited to have, again, 10 abstracts. And so I don't want to belabor this any further. With our first abstract, we're going to start with our first presentation, which is assessing the effectiveness of intraoperative neuromonitoring modalities in spinal dysraphism surgery, a systematic review. We'll have our first presenter come up, introduce themselves and where they're from. Some of these will have more than one presenter.
Great. Hi, my name is Samreen Anise. I am a third-year medical student at the Idaho College of Osteopathic Medicine, and today I will be presenting my research evaluating the effectiveness of intraoperative neuromonitoring modalities in spinal dysraphism surgeries. That's a mouthful. All right. Firstly, conflicts of interest. I don't have any conflicts of interest to declare. However, because I will be presenting this at the ASA conference next month, I will not be disclosing any detailed results or conclusions to stay compliant with the ASA's embargo policy. All right, so some learning objectives. Understanding the role of intraoperative neuromonitoring in spinal dysraphism surgeries, comparing post-operative outcomes for spinal dysraphism surgeries with and without the use of IONM, and identifying limitations in current literature and presenting recommendations for future research. Okay, so background on this. Spinal dysraphism refers to a group of neural tube defects that present at birth and may require corrective surgery at some point. These conditions are classified as open and closed, and they can differ in severity. Some examples include spina bifida occulta, tethered cord syndrome, and lipomyelomeningocele, among others. So some surgical risks that are involved with these types of procedures include CSF leaks, infection, and neurological or urological deficits. So the use of IONM can reduce these risks by providing real-time feedback on the integrity of certain neurological structures. IONM modalities include somatosensory evoked potentials, motor evoked potentials, electromyography, and bulbocavernous reflex monitoring. Through this systematic review, our goal was to assess the effectiveness of multimodal IONM in spinal dysraphism surgeries and to clarify which techniques are the most beneficial in preserving neurological function. On to our methods. So we framed this study as a systematic review and we followed PRISMA guidelines. We located studies between the years 1998 and 2024, and the main database that we used was PubMed. Some of the key words that we used included spinal dysraphism, intraoperative neuromonitoring, spina bifida, pediatric surgery, and neurosurgery. The inclusion criteria consisted of the use of IONM in spinal dysraphism surgeries, English language studies, and any studies that had a sample size of greater than or equal to 10. The exclusion criteria consisted of any reviews, case reports, abstracts, or animal studies. The modalities that we reviewed included the SSCPs, MEP, EMG, and BCR, and all of the studies used an anesthesia protocol of total intravenous anesthesia, notably the use of propofol and remifentanil. So we started off by identifying 99 studies and that we later took into a first phase of screening, which was abstract screening. From the abstract screening, we located 41 studies, and then we took those 41 studies and did a second phase of full text screening, to which we had 24 studies that were included in this project. So some observed trends. The postoperative deficits were defined as urinary and/or ambulatory dysfunction following surgery, and preliminary data suggests that a potential association between multimodal IONM and postoperative outcomes does exist. However, this may be limited by study design or small sample sizes. So I'd like to frame my discussion a little bit around more of the limitations and the recommendations for future research. So out of the 24 studies that we included, only a few of them included a direct comparison between IONM and non-IONM cases, which limits the strength of conclusions. Also, relying on one single database, such as PubMed, could have excluded any other relevant studies that may exist across different platforms. Reporting of false positives and negatives in IONM studies was inconsistent, which makes it really difficult to assess reliability. Variability in study design, patient populations, and outcome definitions further reduces comparability across the studies. So when we put all of this together, the limitations highlight the need for larger, more standardized trials to clarify the role of IONM in spinal dysraphism surgeries. Implications and future directions. So combining IONM with other modalities that target underrepresented neural structures may enhance surgical outcomes. Some examples include autonomic nervous system monitoring, functional imaging, direct nerve stimulation, or high-resolution nerve conduction studies. Also, the addition of urinary bladder EMG can allow for real-time monitoring of urinary function, which could prevent the onset of neurogenic bladder. And as we know, neurogenic bladder is a feared complication of many spinal surgeries. Lastly, pudendal nerve SSCP and urinary sphincter EMG and MEP can offer surgical teams with a more comprehensive approach to detecting postoperative urinary and bowel dysfunction. Last slide, key takeaways. So multimodal IONM does have the potential to enhance patient safety in spinal dysraphism surgeries, and future research in this field should focus on larger, more standardized, and multimodal trials to evaluate the role of IONM in preserving neurologic function and improving patient outcomes. And that is my presentation.
All right, questions from the audience?
So because this was a systematic review and we ended up with 24 studies across the board, when we added up all of the patients, that's how we got a smaller number than anticipated. So I think if we have larger, more standardized trials and on a larger scale with more funding involved, it could be that we could get a more generalized result.
So question, and I don't know that you said it or that you couldn't because you're presenting it at the ASA, but are certain monitoring modalities more specific for detecting certain specific defects?
So I would say in terms of anesthesia, so when we look at the protocol, the total intravenous protocol with remifentanil and propofol, it's shown that that specific combination is more sensitive to transcranial motor evoked potentials, and I think there's another one. I don't remember it at the top of my head, but could you repeat your question?
I meant of the monitoring modalities that you looked at, does one detect a certain defect over others? Not necessarily the anesthetic technique.
Sure. It seems that motor evoked potentials and SSCPs are two of the most, I would say, like up there in terms of monitoring, and that tends to give us the best result.
Thank you.
All right, thank you very much. Our second presentation is entitled Decommissioning Central Nitrous Oxide Piping, Reducing Waste and Environmental Impact. And presenter, come up, introduce yourself, and tell us where you are from.
Hello, my name is Dr. Salah. I'm one of the resident physicians here at Doctors Hospital in Ohio Health. That's in Columbus. And I'm working with student Dr. Ryan Butta. He's at OUH-COM.
So we have a few learning objectives for this presentation. One of them is to look at the environmental impact that nitrous oxide has. Another one is to see innovative ways that healthcare systems have reduced nitrous oxide waste in anesthesia. And finally, some strategies so that we can practically implement these changes in healthcare. So a little bit of background. As we know, healthcare is a major contributor to greenhouse gas emissions, and anesthetic waste is one of those major proponents of that waste. And reducing this waste of anesthetic gas isn't as difficult as you may think. So as we look to the environmental impact that these inhaled anesthetics has, I would like to take your attention to nitrous oxide, which has a global warming potential of 265 times that of carbon dioxide, and it stays in the atmosphere for over 100 years. Also, something interesting to note is that desflurane has a global warming potential of over 2,500 times that of carbon dioxide, and also stays in the atmosphere for over a decade. The National Institute for Occupational Safety and Health stated that studies of workers exposed to nitrous oxide have reported adverse health effects, such as reduced fertility, spontaneous abortion, and neurological, renal, and liver disease. And the recommended exposure limit of nitrous oxide is 25 parts per million, but that is only intended to preserve the mental ability and manual dexterity of those around. There is no recommended exposure limit that exists today to prevent adverse reproductive effects that are shown above until more data is available on this. So Dr. Brian Cheesebrough at Providence Health was one of the first people to identify a problem with nitrous oxide when he realized that the amount of nitrous oxide purchased by his hospital system compared to the amount of nitrous oxide used in clinical practice was very, very different. And so him and his team got together and investigated where all of this nitrous oxide was going, and at CleanMed 2022 presented their work and also went for a solution on how to fix this problem. And in the Discontinuing Nitrous Oxide Playbook in collaboration with the Cascadia Collaborative, Dr. Brian Cheesebrough and his team showed us a solution as well as examples of potential leaks in the central supply of nitrous oxide as shown here. This really brings to light how grave of a situation this is, as leaks in the central supply can happen anywhere in the multiple miles of central supply plumbing that the hospitals have. And we wanted to know if this was happening at Ohio Health facilities. And upon investigation, it was. We saw that around 88% of all of the nitrous oxide produced or purchased by Ohio Health was being wasted, and only about 12% was being used clinically. That led to an estimated 2.88 million liters of nitrous oxide that was being wasted at our facilities every year.
So what is the solution? Dr. Brian Cheesebrough found that cutting out the central supply completely and moving over to e-cylinders directly on the anesthesia machines was the most efficient manner of addressing this problem. Comparing cryogenic tanks to H-cylinders to E-cylinders, you have orders of magnitude improvement in the efficiency and the amount of waste that is prevented. So E-cylinders, if they are open, it has only a very small amount of leak, I believe it's 6 milliliters per minute per tank per machine, versus if it's closed, if you have it off and the provider opens it whenever they want, in the meantime it has zero amount of leak. So big picture, what are the proposed changes that we had at Ohio Health? What was the project that we were trying to implement? We started off with a pilot study to have the e-cylinders set on all of the anesthesia machines, disconnect from the central supply, and eventually move completely over to the e-cylinders and discontinue the central supply. This mimics strategies implemented by other healthcare systems, including Stanford Children's Hospital, University of Michigan. We talked to them, we kind of saw what did they do, how did they approach this, and they gave us some really good ideas. We did a lot of data analytics. One of the things that we looked at is how much work would this require from the anesthesia techs, from the personnel to implement this change. And it turns out each OR really only needs the tanks changed out every so often. The max that we had seen was OR7 and OR2, which would require 8 tanks changed out per year. Other operating rooms really only needed the tank changed out twice a year. So a very manageable and reasonable amount of work. So the pilot study that we implemented back in March was to unplug all of the anesthesia machines from the gas from the central supply. And the hoses, we kept it nearby, adjacent to the machine, so if in a case of an emergency or for any reason the provider needed nitrous oxide, they would be able to hook back up if something went wrong. But E-cylinders were attached to all of the anesthesia machines. And then when the tank neared empty, the machine would alarm, the provider would let the anesthesia tech know, and at the end of the day would come in and replace it. It turns out by the time it alarms, there's still almost a week's worth of nitrous oxide still in the tank. So there isn't a major rush. Getting into the logistics of it, here's kind of one of the images we have of our anesthesia machines where the nitrous oxide was attached. Some of the machines needed to be retrofitted to be able to house the E-cylinders on the back and be able to adopt that gas in. That costed about $10,000. And then future would be to completely discontinue the supply. What would need to happen is basically we can abandon all of the pipes in place. We wouldn't need to do any major construction to pull out the piping or anything like that. We would have MedPipe come in and disarm all of the alarms along the hospital for the nitrous oxide. And then at that point, it would just be turning off the valve in the central supply, and that's it. So when we presented this project at Grady, even without requiring them or asking them to reduce the amount of nitrous oxide they were using, we saw a precipitous drop, and that has maintained. Same thing at Doctors Hospital, just making providers aware of the issue with nitrous oxide has seen a decrease in the amount of usage. And then long-term savings, nitrous oxide is actually very cheap. So for all 2.8 million liters that are wasted, it ends up being about $50,000 per year. But the long-term savings comes with the replacement of the piping system. If every decade or a couple decades, the piping system needs to be repaired and replaced, that can be on the orders of millions. And the next steps for our project is to receive formal approval from the president and from other key stakeholders to move forward with the project. We haven't run into any major issues with the pilot study, and so we're planning on repeating this not only at Doctors, but the other healthcare systems in Ohio Health. And here are our references. Again, we are greatly grateful to Dr. Brian Cheesebro for making his work publicly available. What questions do you guys have?
Any questions from the audience?
Yeah, so desflurane. That was another project that our hospital embarked on a few years ago. We actually completely removed desflurane from all of our anesthesia machines. The vaporizer was completely removed, and so it's no longer available at Ohio Health. That was a big project. It took a lot of people to get on board and selling it. A lot of providers really enjoyed using nitrous or desflurane, so getting everyone on board with that was a challenge, but it has been very, very great. Go ahead.
Were there any certain nitrous?
I think those two specific ORs are ones that are either for emergency cases, and so they're more likely to be running night and day. That was just my impression. Yeah, so at Ohio Health, we don't do very much pediatrics. So that is one of the things that it would be interesting to look at. Perhaps I can talk to some of our fellows over at Nationwide and Children's Hospital over there, see how much they use. But I have other providers who use it very frequently, and even with those people who are within our system, like looking at Doctors Hospital specifically, we are 4 or 5 times more than some of the other hospital systems in terms of nitrous oxide use. And even with that, we only reached 8 tanks changed out per year.
We recently started using nitrous in OB, and our nurses handle that, the OB nurses do, and it's not a central supply, it's a separate tank. I noticed there was something with OB on yours as well. Do you guys use it a lot? Is that going to impact anything here?
Yeah, so that's actually a major discussion. Over at Riverside, some of the doctors there use it as part of their emergency OB section, one of the drugs that they use in those kind of situations. And for them, if nitrous oxide were not available in that emergency situation, they expressed to us that they wouldn't be wanting to run around to the back and, trying to change out of the tank or anything like that. It has been a challenge to express to them that we have safety backups, and like you have a week before when the tank starts to alarm to when do you need to change out the tank and how much is needed. But it's part of getting first the set of ORs in the main hospital system, getting them comfortable with that, seeing that we haven't run into any problems where X number of months in and no one's had any issues. Then converting that over to OB, and that there's also other anesthetics that you can use in those kind of situations.
Right. With our OB, yes, we use it a lot for sections if we have to supplement, if we have a general anesthetic section. I'm specifically referring to nitrous oxide in labor, which a lot of places don't do. It's a contained system. It's supposed to only trigger when the person is taking a breath. There is some waste with that. We have no data on whether that is very significant or not, but that's something to look at too. I think the utilization in your ORs for emergency cases, though, you're going to need it over there. And if it were my hospital, I would make sure that didn't go away. But we've done something similar, kind of decreasing the amount of nitrous used in the OR. But labor and delivery, don't touch it.
Yeah.
Thank you so much. Our next presentation is entitled Risk Factors for Chronic Post-Surgical Pain Following Orthopedic Surgery, Who's at Risk? We'll have the presenter come up and introduce themselves and tell us where you're from.
Right. Hi everyone, my name is Brandon Eichler and I'm a third-year medical student at the Chicago College of Osteopathic Medicine in Chicago. Today I'm going to be talking to you about chronic post-surgical pain, the associated risk factors with this condition, and various treatments and prevention plans that we can put in place. Okay. So learning objectives for this study, or this presentation, we want to define CPSP and describe its prevalence. We want to identify perioperative, intraoperative, and postoperative risk factors for CPSP. We want to discuss evidence-based strategies to reduce CPSP risk and analyze emergent areas in CPSP prevention and management. So for this study, we meant to assess the risk factors for CPSP and what we can do to prevent and treat this condition. We looked to compile the results of multiple larger meta-analyses and trials that individually assess these risk factors. And we found that the occurrence of CPSP is influenced by a multitude of risk factors that can be present before, during, and after surgery. So to begin, what is CPSP? Well, it stands for chronic post-surgical pain. This is a relatively new diagnosis, and it was only officially named in 2019. This is defined as pain that develops post-surgery, and it can be due to tissue injury directly following surgery, or it can be due to scar tissue formation later. It lasts 3 months or longer, and it actually makes up 15% of pain clinic cases. So for potential risk factors, there's a variety of different categories that we put this in, both perioperative, intraoperative, and postoperative. And I'm going to go into these risk factors kind of as we go along, just because there's quite a few of them. So for analysis of pre-risk factors, we used 3 different studies to look into this. So first off, we wanted to look at BMI. So a 2020 overview of weight loss recommendations prior to total knee arthroplasties actually looked into various post-surgical outcomes after patients lose weight versus if they didn't lose any weight prior to their surgery. And they actually found that there was a very weak association with weight loss in the development of post-surgical pain. And this was kind of unexpected because typically with like TKAs and total hip arthroplasties, these are weight-bearing joints, and we thought that perhaps weight loss would be something that could help prevent this condition from occurring. But the association was very weak. A 2018 meta-analysis and systematic review of CPSP looked at depression and anxiety and that prevalence before surgery took place. and used the Spielberger state trait test for anxiety and Beck depression inventory for depression to quantify these disorders. And they found that higher scores on this scale actually correlated with an increased risk of CPSP. Lastly, Chinambaran et al. 2020 and another 2023 meta-analysis both found that there's actually multiple gene polymorphisms that are correlated with an increased risk of CPSP, including one called KCNS1, OPRM1, and COMT, which is a very familiar catecholamine breakdown gene. For intraoperative risk factors, there was multiple of these. Mostly we looked at whether length and type of surgery was a factor. And it was actually found that complicated, more lengthy surgeries were associated with increased risk for CPSP, such as an occurrence of only 5% for laminectomies, which is relatively simple compared to a spinal fusion, where 85% of those patients developed chronic post-surgical pain. Another 2023 analysis found a correlation where increased surgical complexity and duration was a factor, and they found that this was due to increased tissue trauma and nerve injury risk when there are longer surgeries. So they found that laparoscopic and arthroscopic surgeries were much less likely to have CPSP from developing post-surgery. Lastly, there was a 2023 prospective study on chronic post-surgical pain in the elderly, and they found that general anesthesia was more correlated with an increased risk of CPSP rather than local anesthetic practices, such as they found in 28% of patients where general anesthesia was used, CPSP occurred, versus 10% where regional anesthesia was used. Lastly, we looked at post-operative risk factors, and there was a study in 2014 that found that 22 of the 40 surgical procedures that they looked at, 22 of those were orthopedic. So orthopedic surgery is a very prevalent, CPSP is very prevalent in orthopedic surgeries, and high pain intensity after 30 days was associated with higher CPSP risks. So if a patient has acute severe pain, they're likely to eventually progress onto CPSP. And it was actually found that 30% of patients experiencing severe acute pain transition to CPSP, but those exact percentages are actually unknown. Lastly, 2024 meta-analysis found that greater cumulative opioid consumption was correlated with more severe acute pain, which makes sense. And they found that every 10 milligram equivalent morphine increase per day following THA correlated with a 10% increase of CPSP occurrence at 6 months. So now that we've looked at risk factors, we want to look at how we can treat and how we can prevent CPSP. So for preoperative treatments and preventions, a 2021 meta-analysis found that significant reductions of CPSP could be found with the use of ketamine, IV lidocaine, and pregabalin prior to surgery. Although this study did have some issues because it had small sample sizes and heterogeneity of endpoints and heterogeneity of the endpoints, so this indicates that more research is needed in this topic. That specific meta-analysis looked at about 110 different studies, and most of them had small sample sizes. So we think that more research is needed in this topic to get more funding so that we can have higher sample sizes. Another 2021 review and meta-analysis had 122 studies, and they concluded that peripheral nerve blocks lowered the risk of post-surgical complications. But this also contradicted with another 2023 meta-analysis where they actually found mixed results. So again, this shows that there should be more research in this area. For intraoperative treatments, a 2002 randomized controlled trial found that thoracic epidural blocks and regional anesthesia were associated with decreased CPSP incidence. So again, not using general anesthesia when possible. And then a 2023 study used intraoperative bupivacaine around surgical sites, And it was found that this reduced the likelihood of CPSP developing significantly from the placebo group. And lastly, arthroscopic and laparoscopic techniques were found with reduced incidence of CPSP, as well as surgeons and anesthesiologists could use nociceptive monitors on the patient, such as monitoring pupil diameter and using heart rate monitors to determine pain levels that possibly the body is perceiving during surgery. And looking at that, they could be able to determine different strategies to help relieve possible pain from that patient. Lastly, reducing intraoperative opioid exposure was also seen to significantly decrease CPSP incidence. And then finally, post-operative treatments. We found that using ketamine for more than 24 hours post-surgery was actually correlated with a reduced risk of CPSP at 6 months, but this also had small sample sizes for their trial. We determined that more research is needed in this area. The use of NSAIDs and COX-2 inhibitors as opposed to opioids was also shown to reduce CPSP risk. And lastly, early lifestyle mobilization and modifications and physical therapy was very helpful in relieving pain and decreasing CPSP risk. So in conclusion, we found that CPSP remains a frequent complication after orthopedic procedures. There's multiple different areas of risk factors, and the most helpful treatments that we found were early targeted strategies that can reduce chronic pain development post-surgery, and that comprehensive multimodal management is the most effective way to help these patients. And that's it. Thank you.
We only have time for one question. Anyone want to take it? Okay, our next presentation is entitled Efficacy of Opioid-Free versus Opioid-Based Anesthesia in Elderly Patients for Orthopedic Surgery. We'll have the presenter come up and introduce themselves and where you're from.
Hi everyone, my name is Anushka Roy. I'm currently a fourth-year med student at NYT Com in Long Island, New York. And today my project is a systematic review and meta-analysis on the efficacy of opioid-free versus opioid-based anesthesia in elderly patients undergoing orthopedic surgery. So the background and the inspiration for this project is the opioid overuse epidemic. Specifically in this patient population, recent studies have shown that elderly patients undergoing orthopedic surgery, including hip fractures and multiple fractures, show that opioid-naive patients post-op, they showed 23 to 41%, showing chronic opioid use greater than 6 months post-operatively. And also pre-op users who have been using opioids before the actual surgery show 70 to 80% chronic opioid use. And also the perioperative pain management in older patients greater than 65 is challenging due to age-related physiological changes in drug metabolism and liver and kidney metabolism, and there's also increased sensitivity to therapeutic and adverse effects. Some alternatives to opioids that I'll be discussing today are regional blocks, dexmedetomidine, also known as Precedex, ketamine, and magnesium sulfate. Also, there's also low-dose spinal anesthesia that can be used in addition to these techniques as well. So the learning objectives is to consider the alternatives to opioid use and to objectively evaluate whether they provide adequate pain management, as well as minimizing the opioid-induced adverse effects, such as perioperative hypotension, postoperative nausea and vomiting, and postoperative delirium. So I conducted a systematic review and meta-analysis, gathering articles using keywords such as opioid-free anesthesia in elderly populations. And after screening about 100 studies, I came to 5 studies that compared OFA to OA outcomes in the elderly population undergoing orthopedic surgeries. And this included 442 patients in total. And the statistical analysis was a fixed effects model for the mean differences in the numerical rating scale, which is basically when the patient says from a scale of 1 to 10 how much pain they are and postoperatively, and also using the random effects model for the odds ratios for the events of hypotension, nausea, vomiting, and delirium. Here is the results for the numerical rating scale for the pain, and this shows that there's significantly less pain when using the opioid-free anesthesia as compared to the opioid-based anesthesia. Here we can see a significant decrease of 1.16 points with a significance, a p-value of less than 0.001. And on this side, you can see the forest plot with the 4 different studies, and you can see where the mean difference lies. Next, we have the results for the perioperative hypotension. So in each of these studies, it was measured how many times the patient had the episode of perioperative hypotension, and it showed also a significantly decreased events of hypotension in these patients as well. Also, postoperative nausea, vomiting was also decreased between OFA and OA with a p-value of less than 0.01 investigating these 4 studies. So overall, opioid-free anesthesia is an effective method for pain management. It provides adequate pain control and decreases the possible adverse effects in these specific populations undergoing these surgeries. However, I did analyze the effect of postoperative delirium, which was not significantly altered. This could be due to confounding factors such as the judgment of the anesthesiologist using a more conservative approach when approaching these patients with the opioids. In the future, further randomized controlled trials are needed to offer evidence which specific method of administering opioid-free anesthesia, whether it's low-dose spinals in addition to ketamine and Precedex, or whether it's using low-dose spinals in addition to other regional blocks as well. And also to investigate long-term outcomes such as recovery time and analgesic requirements postoperatively. These are some references, and thank you. Any questions?
Questions from the audience?
Yeah, basically the patients weren't on a regular regimen of taking opioids outside of before the surgery. So they might have used it in the past for previous surgeries, but they're not on a chronic pain regimen, including opioids in their daily use, or PRN even. Yes, yes. Yeah, so the statistics showed between 23% and 41%. There was multiple studies based on that, but the range was basically 20 to 40 around, yeah. Which is very interesting to see. It's a very prevalent issue that we're facing here.
Other questions?
I might have missed this in the beginning. And orthopedic surgery, specifically joint replacements, just ACLs, that sort of thing, it was no orthopedic spine surgery, correct?
No, no orthopedic spine surgery. Basically knee arthroscopies, hip replacements, and any other fractures, but no spinal surgeries.
And for people that were on chronic opioids, did that also include methadone as well? For patients that were on methadone for maintenance, it included that as well, or?
I'm not completely sure on that.
Okay.
I'll definitely have to double check, but I don't believe so.
Okay, all right, thank you.
Of course, thank you.
What do you think, and this is a tough question,
Okay.
the most efficacious protocol will be in this type of surgery? Combination of what do you think would be the best?
I think using a combination like a multimodal analgesia approach, coming in with a regional block is so helpful. I see, even in day-to-day life, I see when I'm in the OR and the patient receives a block, even after the surgery, a couple hours, I check back in, the patient doesn't have pain. They can't feel it still. It depends on what agents you use for that block, and that would be really interesting to see if adding other agents to the block, such as epinephrine and if you add other things, if you can prolong it, but I think that could be really useful.
And or catheter use. But after that's done, to maintain them, most of them can go on non-steroidals, things like that, or still using something else, say post 3 days and beyond?
So I'm not too sure about, so postoperatively, that was kind of a limitation of this study because I didn't follow up on these studies, didn't usually follow up on the patients postoperatively to see what they used in terms of analgesia.
Okay, and that
afterward.
might make a difference.
Yeah.
Thank you.
Thank you. Thank you so much, everyone.
We had one other scientific investigation that had to cancel at the last minute, so the next set of abstracts are going to be complex cases. And the first one is telogen effluvium and anesthesia considerations. And we'll have the presenter come up, introduce themselves, and tell us where you're from.
Hi, I'm Samantha Courier. I am a PGY1 at Ohio Health.
And hello, I'm Elizabeth Gray. I'm a PGY3 also at Ohio Health Doctors.
And we're going to go over a case of a patient with telogen effluvium and some of the anesthesia considerations. Okay, perfect. These are some of our other colleagues at Ohio Health within the anesthesia and internal medicine department who helped us with this project. For this case, we're going to talk about telogen effluvium, what it is and what can cause it. We're also going to try and understand the surgical intervention and anesthesia that could be a trigger to worsen these patients' symptoms. And then we're going to review anesthetic considerations that can help minimize the risk of patients having hair loss directly after their surgery. So this patient was a 61-year-old Caucasian female who was coming in for reduction in internal fixation of a left tibia repair and a repair of her left lateral meniscus after a fall. This was done under an emergent condition and was not a planned procedure. Her past medical history included asthma, acid reflux, history of post-op nausea and vomiting, and telogen effluvium. She reported that she had previously had a telogen effluvium exacerbation after her previous surgical appendectomy, and she lost hair from one whole side of her head. And in this case presentation, we're going to talk about how can we decrease her risk before she goes to surgery. So telogen effluvium is when you lose a significant amount of hair due to the hair follicles prematurely entering the telogen phase. This results in excessive shedding, and it can be very difficult for the patient to have to experience this. It's non-scarring and temporary, so a lot of times the hair will grow back. The exact mechanism in which this occurs is unclear, but it is believed to involve alteration in the hair follicles and in the hair growth cycle. It can be caused by various infections or diseases, having any kind of major surgery, having a low protein intake, having significant hormonal changes, going under extreme stress, or certain medications can also trigger it. Basically anything that puts excess stress on your body, so definitely having surgery is a risk factor. So when we looked this up when the case was happening, there aren't a lot of papers out there that talk about what best practices are for patients who have this and who are undergoing anesthesia. So there weren't any specific guidelines or reports. So we kind of called on our teammates in internal medicine and people who had some endocrine background to help give us some information on some of the triggers, as well as doing some quick research to figure out what we could do prior to taking that patient back to the OR. Some of the possible triggers that we tried to avoid was excessive UV light, so the lights were turned down in the OR. Beta blockers have also been shown to cause exacerbation of this disease, and also significant temperature changes. So that's something that we do in normal cases. We're trying to make sure that we're not having huge fluctuations in temperature, but something that we definitely paid attention to extra in this case. Minimizing the patient's anxiety and stress. So we did that before the procedure by giving anxiolytics. And then proactively treating the nausea and vomiting, because Nausea and vomiting can put extra stress on the body, and she has a history of post-op nausea and vomiting, so if we could keep that under control, that would decrease stress. And then managing pain control with a multimodal approach. So preoperatively, we gave her midazolam, and we gave her aripiprazole and a 1 liter bolus of lactated ringers and albuterol to help treat that post-op nausea and vomiting. We also did a femoral nerve block to help with pain control. Intraoperatively, induction was with propofol, sufentanil, and succinylcholine, followed by a complete TIVA, and we avoided beta blockers throughout the case. We also gave dexamethasone and ondansetron to help with post-op nausea and vomiting. Pain control was continued with sufentanil and ketorolac. And for temperature control, we used a bear hugger or a forced air warmer and kept the temperature between 36.5 to 37.5 degrees Celsius, so we kept it in a very tight range. For avoidance of UV light, the OR lights were dimmed, and the patient was also covered with an extra surgical drape. Her hair was wrapped in a silk scarf to just prevent any kind of damage with her head being on the table. And then the orthopedic team, we told them about how important it would be to try to have the most minimal amount of blood loss as possible. I know that we try to do that with every case, but that is something that really could affect her and her telogen effluvium. And she was extubated without difficulty. Post-operatively, her pain was well controlled. She had a few extra things given to her, and then her post-op nausea and vomiting was well controlled because of all of the pre-medications that we gave her preoperatively and in the case. So we followed up with the patient after 1 month, 3 months, and 6 months, and the patient only had very minimal hair shedding and was extremely appreciative that we took the time to listen to her concerns, and even on an emergent basis, we're able to kind of call on some of our colleagues and do some research so that we could make her anesthetic plan as favorable as possible so she did not have to experience that. We gave her an exact outline of all the things that we use so that she could take that to any surgery she has in the future to let her anesthesia team know what worked for her. These are some of our references, and does anyone have any questions?
Before we get audience questions, I just want to say that my mom, God rest her soul, told me years ago that her hairdresser told her that this happens after anesthesia. And I said, she's full of crap. Well, Mom, if you're up there listening, I was wrong. Anyway, I have a quick question. Were you able to look at this woman's anesthesia record from a prior surgery to see what she had and what she didn't have?
Yes, so that was kind of part of it. She actually had her lap appy at our institution 2 years prior, and she didn't have any TIVA, so that's where her PONV was horrible, and she had only got, a standard, 2 of Versed, 100 of fentanyl, and nothing of the other stuff that she had kind of gotten in with this, and she had said she had horrible PONV, and she actually lost. They qualify hair loss with this condition as like clumps of hair, because it's really hard to quantify how much hair you're losing. So she would say she would lost clumps of hair, usually to 3 mark, and then 6 month out. And it described almost the entire left side of her hair as of coming out. When I met her in this surgery before, she was very, as you can imagine, I think most of us, especially women, would be very self-conscious about our hair, was very nervous, very anxious. So it was a conversation we had with her. I called the ortho team in. We called IM. Thankfully, I was lucky to have an IM resident that was interested in endocrinology at the time and actually saw some of these patients out in recovery. So kind of had talked to me through of, hey, my patients, I see this as a big trigger, like UV light's a big trigger, pain is a big trigger, nausea and vomiting is a big trigger. So we're kind of able to, with all of that, kind of formulate a plan and then talk to ortho of hey, this is what we're thinking, this is kind of what we do, is this feasible in some of your procedures, for instance, like turning the lights off? Is this feasible during some of your things to dim our lights or try different things to kind of see, since we have nothing really to go off, is this going to work? Is this going to tolerate well with her? So
Right. Fascinating. So, questions?
that was just bolus dosing. Mm-hmm. Yeah, I would say it was more of a deep extubation, just because we weren't exactly sure, with a stress of intubation, her heart rate goes up, all the things, right? So she had about 0.3 of MAC on, and she just was kind of starting to after be on pressure support and go on manual, and then we pulled. Yeah. So I'd say maybe more of a modified. Yeah.
She had a case recently similar where a patient who was sort of urgent, and the patient said, "Oh, I can't have UV lights." We didn't have a name. We didn't know that, but she knew what this was. But she knew she couldn't have UV light exposure. And of course, that was very challenging in that case.
Yeah, I was talking to my internal medicine colleague, and I guess, the biggest trigger is UVC, which I think is 200 to 290. And we don't think in the OR it happens that much, but a lot of times the lights in the OR do have a tendency to have the C for infection protocol and stuff. And so something that they're doing actually more now with lupus patients is there's a whole new study that she was telling me. They're looking at changing light bulbs even in these patients' home to minimize some of that UV exposure. So even in the home, they're not experiencing so much of that can be a trigger.
I did have one question about, you described what is in fact just a very excellent, thorough, robust anesthetic for someone with severe PONV.
Mm-hmm.
Everything you did is not very far off what you might do. I'm wondering if there's anything specific you think in the medication
Specifically for PONV.
or for
Telogen.
I think not necessarily specifically for PONV. I've definitely done this for people that have PONV. I think we were just a little bit more cautious with maybe doing like Sufenta, doing some like the block. Normally in these cases, we actually usually don't do a block for them. It was just more of kind of trying to find the different ways to decrease her risk of exacerbation. And her specifically, I learned this from her too. Some of these patients, they know what triggers them. She said pain is a big trigger for me. She said if I'm in pain, spraining an ankle, anything like that, I will lose hair. So that's a big thing that we really tried to focus on, specifically with her, was kind of minimizing that risk since she knew what triggers her the most.
Also being sure to avoid beta blockers. That was one of the big medications. They aren't completely sure of the mechanism, but it has been shown to cause worsening of telogen effluvium.
Oh, no, that was just for her asthma. Yeah, and she takes that at home too. And she had actually used it earlier in the week. So, yeah. So the beta blocker mechanism, they think, which I did not know this, I learned this too, they think is to reduce blood, possibly reduce blood flow to the area. And they do also think there's some hormonal changes that can actually trigger the hair state from going into its normal active to all of a sudden its reactive state. My endocrine friends were great about that.
We can't just do that for our legs, right?
I know, right?
Yeah.
Okay, no more
Thank you, guys.
questions. We're out of time. Thanks so much. Okay, our next complex case is managing difficult airway in a patient with adrenal insufficiency. Presenter, come up, introduce yourself, and tell us where you're from.
Alrighty, my name's Lauren Sherman. I am an intern at Doctors Hospital.
And my name is Mary Mohammed, and I am a fourth-year medical student at Ohio University Heritage College of Osteopathic Medicine.
We're going to be discussing today managing difficult airway in a patient with adrenal insufficiency. We have no conflicts of interest. I'm going to start off with a little bit of a background on this case, first discussing emergency airways. Emergency airway management is a critical aspect of acute care, often required in the setting of rapid airway compromise. So when we think rapid airway compromise, we often think obstruction. Obstruction can occur due to angioedema, resulting in significant airway swelling, anaphylaxis, which can result in swelling of the tongue, lips, soft palate. We also think infections such as retropharyngeal or peritonsillar abscess, tumors such as lymphomas, tracheal tumors, or thymomas. For this specific case, we're going to focus on deep neck infections. So deep neck infections themselves present particular challenges due to the distorted anatomy that can result from them, limited mobility, and edema also associated with them. Next, I'm going to talk a little bit about fiber optic intubation. So this is a specialized airway management technique used to secure the airway in patients where we are expecting difficult or high-risk intubation settings. It often involves inserting a flexible fiber optic bronchoscope through the mouth or nose while the patient is awake and spontaneously breathing. This does come with risks, however. These include hematoma, epistaxis, patient discomfort, hemodynamic instability, or aspiration. This case does highlight fiber optic intubation for deep neck infections, complicated by adrenal insufficiency and cardiovascular collapse. emphasizing the need to recognize endocrine causes of shock in emergency airways. Some learning objectives that we're going to focus on: understanding the risk of adrenal insufficiency in glucocorticoid-dependent patients undergoing surgery, discussing the potential life-threatening consequences of unrecognized adrenal insufficiency and importance and prevention of timely treatment, identifying the clinical signs and symptoms of adrenal crisis, explaining the physiologic role of glucocorticoids in supporting adrenergic receptor function, and outlining perioperative glucocorticoid dosing for patients with known adrenal insufficiency, including timing and dosage. So a little bit into this case, this was a 40-year-old man. He had a history of pituitary adenoma resection that we were actually not aware of, as this was an emergent case that the patient was presenting with. This did result in diabetes insipidus, and he was on daily desmopressin as well as hydrocortisone. He presented to the ED due to difficulty swallowing and a sore throat. The patient had significant swelling of his right peritonsillar region, painful swallowing, and a hoarse voice. CT imaging of his neck revealed a large fluid collection consistent with a retropharyngeal abscess with concern for airway compromise. After ENT evaluation, anesthesia was urgently consulted to complete an awake fiber optic intubation in the OR. Post-intubation and after the first incision was made, the patient did develop some significant hypotension. We placed an arterial line, and initially we attempted to manage him with phenylephrine. We used about 400 mics for him, but this wasn't working for the patient. We quickly transitioned to epinephrine, and we used about 1,200 mics. Also really difficult to raise his blood pressure. After completion of the case, he was transferred to the ICU. It was discovered in the ICU that the patient had missed doses of his daily home steroids for his adrenal insufficiency. Glucocorticoid replacement was then initiated, resulting in improvement in blood pressure and stabilization of the patient.
So now we'll go into discussion of the case. So postoperative dysfunction of the HPA axis is a pretty well-known complication in patients following pituitary adenoma resection, such as the patient that's discussed in this case. For our patient, they showed signs of quick deterioration, again, because of their previous pituitary resection and the misdosing of their steroids at home. Adrenal insufficiency can lead to adrenal crisis. This is a medical emergency typically manifesting as hypotension, shock, some electrolyte imbalances such as hyponatremia, hyperkalemia, and metabolic acidosis. It is helpful to get baseline labs in this case, such as BNP and cortisol, if there is a suspicion of adrenal insufficiency. But just to note, diagnosis of adrenal crisis should not be confirmed before treatment, since this is a medical emergency. Glucocorticoid-dependent patients are especially vulnerable to complications from the physiological stress of surgery, especially if they are, again, in this case, have a baseline lower cortisol. The stress of surgery triggers increased pituitary hormone secretion and sympathetic nervous system activation. So in terms of the role glucocorticoids play in the heart, vasculature, and just general sympathetic response, they will increase the expression of beta receptors on the heart. This kind of influences the intracellular signaling pathways that are activated when catecholamines like dopamine, norepinephrine, and epinephrine bind to their receptors, and this produces certain desired effects, such as increased cardiac output or vasoconstriction. So for our patient, intraoperative collapse and lack of response to the normal vasopressors, epi and phenylephrine during the case should prompt questioning of possible adrenal insufficiency, or in their case, adrenal crisis. And at this time, stress dose steroids should be considered. Early recognition and stress dose glucocorticoid administration are pretty critical for restoring hemodynamic stability and preventing further deterioration in patients. So in terms of the guidelines that are recommended for hydrocortisone dosing, it is actually based on surgical severity. So on this slide, we highlighted what it was for our patient, but for example, in minor cases like an inguinal hernia repair, the patient should take their usual daily dosing
plus hydrocortisone 50 milligrams IV before incision, and then subsequently hydrocortisone 25 milligrams every 8 hours for 24 hours. Versus in major cases, the patient should again be taking their usual dosing of steroids, followed by 100 milligrams IV hydrocortisone before incision, and then subsequently 50 milligrams IV or intramuscular dose every 6 hours for 24 to 48 hours. So in conclusion, awake fiber optic intubation remains an essential strategy in managing complex airways, particularly in cases involving deep neck infections, such as the case presented today. Unrecognized adrenal insufficiency in the perioperative setting can result in adrenal crisis, which is again a medical emergency and is potentially fatal complication if not quickly identified and promptly treated. Intraoperative refractory hypotension, especially unresponsive to standard vasopressors, should prompt consideration of stress dose glucocorticoids to stabilize hemodynamics and improve outcomes for patients. This case emphasizes the need for heightened clinical suspicion of adrenal insufficiency in patients who are unstable undergoing emergency airway management, especially when standard interventions fail. And these are our references.
Any questions?
Questions from the audience?
The patient had been given Decadron before the case, or during the case. The issue was we gave it, so we ended up giving it afterwards. So he started having severe hypotension, and so they were trying to monitor his blood pressure strictly, and therefore, it was kind of given later in the case than we would typically give it because we were so focused on getting his blood pressure up with the phenylephrine and epi. So it was given a little bit later. So I wonder how that would have impacted him if we had given it a little bit earlier. But we did end up giving it before the case had ended for post-op nausea and vomiting, yeah.
I agree that probably your conclusion was correct here, but do you think sepsis from the neck abscess could have entered into this severe hypotension as well?
Absolutely. I just think that we would have expected better response even then to the phenylephrine and epinephrine that were given during the case in order to kind of correct for that intraoperative hypotension. But sepsis definitely was considered. Something else that was considered was the potential for vasovagal during the case because the moment of hypotension didn't happen with induction. It actually happened after the first incision was made. So there was a consideration for vasovagal as well.
Okay. Other questions? Okay, thank you so much.
Thank you.
Thank you.
Next is a complex case entitled A High Wire Act, The Art of Anesthesiology When Surgical Problems Collide. Presenter, come and introduce yourself. Tell us where you're from.
Good morning. I spoke earlier, so some of you may have been here. My name is Shelley Iverson. I'm an anesthesiologist and intensivist at the University of Nebraska in Omaha. Today we're going to be talking about a complex case that I had where the patient actually had 3 surgical issues, all of whom collided with one another, and it was a matter of picking the right one. I have no disclosures that are pertinent to today's topic. Learning objectives, we're going to review and discuss the pathophysiology and the incidence of von Hippel-Lindau syndrome or disease. We're going to review and discuss the most common presentation for this patient and the most common cause of death for these patients. And then we're going to discuss the need for multidisciplinary approaches to complex patients who have disease processes with conflicting treatments. So von Hippel-Lindau disease is caused by a mutation in the tumor suppressor gene, the VHL gene. It is autosomal dominant with very, very high penetrance, more than 90%. And though most cases are actually familial, about 20% occur de novo. Incidence is anywhere from about 1 to 30 to 50,000 people. It tends to have its presentation in young adulthood, so teenage and up, though it can present in infancy. And so for those pediatric anesthesiologists in the community, you will see these kids because they actually do need imaging scans pretty early in life. So we're going to start off with my case, 49-year-old female who presented to the ER with complaints of chest pain, palpitations, and shortness of breath. It actually began a day prior and woke her up from sleep. Woke her up in the middle of the night. She had been doing nothing exertional. And then upon further review of questions, she had also incidentally noted this worsening headache. She complained of some visual problems, and though I'd never met her before, speech, she answered everything appropriately, but was just very slow to get her words out. And she and her family had confirmed that speech seemed to be more and more delayed in the coming weeks. History, significant for von Hippel-Lindau. She is on active chemotherapy, insulin-dependent diabetes, hypothyroidism, and CKD3. Pertinent surgical and oncological history. She's actually had CNS tumors ×4. Necessitated craniotomy ×2 with tumor excision, 2 different spinal cord tumors requiring that incision and surgery. She's had renal cell carcinoma separately twice, resulting in a complete left nephrectomy and a partial right nephrectomy, hence the CKD. Thyroid cancer with a total thyroidectomy, hence the thyroid hypothyroidism. And then she actually had pancreatic tumor and status post-Whipple. And interestingly, her path on that had both neuroendocrine tumor and mesothelioma. So CT imaging upon admission, she had new cystic cerebellar lesions. She had significant cerebral edema, mass effect, and early ventricular displacement, so herniation. She actually had a new large tumor in the remaining partial right kidney that she had that led to some obstructive uropathy. And she had tumor and thrombus that extended from this right renal mass through the renal vein, up the IVC, and it terminated in a very large right atrial mass. And so I lied and said I didn't have anything to point to. Here we can see the black dot in the center is actually the cystic mass, and then the white around there is the edema, and we can see there she's got some herniation. This is the remnants of her right kidney. We can see tumor extending into thrombus going into the atrium of the heart. On TTE, so we have left atrium, LV, right atrium, right ventricle. We have a very large right atrial mass, that's the circle. And then cardiac MRI, again, well circumscribed mass. Noteworthy labs in the ER, she had AKI on CKD and a new metabolic acidosis. She was hyperkalemic, non-hemolyzed, so her hyperkalemia was temporized. She did not have EKG changes with this. She underwent an emergent nephrostomy tube placement in IR that night. Additionally, she was admitted to the ICU, started on a heparin drip because of this thrombus, started on dexamethasone for her vasogenic edema. Unfortunately, this led to DKA, so that was subsequently managed. The following morning, because of course they come in the middle of the night, the following morning she had a TTE and a cardiac MRI. EF was preserved, normal RV function, and no evidence that her RV was not tolerating this large mass that was there. She had an urgent multidisciplinary tumor board meeting consisting of oncology, neurosurgery, CT surgery, and urology. CT surgery was involved specifically because we were talking about having her potentially undergo embolectomy, thrombectomy, neurosurgery for the brain tumor, urology because of the mass and the obstruction, and then of course her oncologist. And amongst the different specialties, the ultimate final decision was that we were going to undergo an urgent decompressive craniotomy first because of the early ventricular displacement. Unfortunately, this meant that at a minimum, she was not going to have any anticoagulation, either prophylactic or therapeutic, for at least 4 weeks post-procedure. So she proceeded down to pre-op. We had very, very hard conversations. The surgeon and I actually spoke the night before, and he called her and then subsequently went up to her room, called her family, had them show up to the room, and then all of us had a conversations about what things were really going to look like. I also talked to my partners who were on my ICU team since I wasn't on the ICU service, but we were all in an agreement that in the event of intraoperative cardiac arrest, she was not going to be a candidate for mechanical cardiac support, so something like ECMO. And this was because of our inability to anticoagulate her, but also because she had active malignancy despite chemotherapy. So she had 2 contraindications. And in the event of intraoperative death, she was going to be not resuscitated. Again, hard conversations that we had before going in there, and as such, her code status was changed from full code to DNR. She was consented for pre-op A-line, which we already had, or which we put in. TEE, if we needed it, femoral central line, and transfusion. I was not sure how she was actually going to tolerate positive pressure and induction, so we started pretty slow and controlled. I still use etomidate when I need it, so rather than propofol, we induced with etomidate. She tolerated it well, no issues. Central line was placed femorally. And then intraoperatively, she actually did well, though required a lot more product transfusion than initially anticipated by the surgeons. Surgeons actually requested that she remain intubated for a couple days. They were pretty concerned about the amount of bleeding they had, and they wanted serial scans to follow up. And so our discussion, historically von Hippel-Lindau, characteristically, these patients will form tumors or cysts, and these can be both benign or malignant in nature. Tumor types, most common CNS are going to be benign tumors, which are hemangioblastomas. And while she historically has had 3 of them in her brain leading now to her 3rd craniotomy, they actually have a predilection for retinal, and so often enucleation or other optical or ophthalmology surgeries are needed. Renal cell carcinoma, this is actually the most common cause of nephrectomy. That is because of hereditary issues. Pheochromocytoma, and again, neuroendocrine tumors. The cerebellar hemangioblastoma is the most common presenting lesion and is actually the most common cause of death in these patients. Women, unfortunately, have a life expectancy a little less than men. In my research, I wasn't able to find out why this is, so I have 2 very good friends of mine that are both oncologists, and I reached out to both of them. And they said that while there is nothing that is clearly ever been demonstrated, they do think that there is largely a hormonal driving factor. The women also tend to have more malignancy than the men. And so between what they think is going to be some hormones and the fact that women have more malignant, on average, we will die 10 years earlier. Our patient was extubated on post-op day 3, neurologically intact. Actually, speech was normal when I went up to see her, just out of my curiosity. She was discharged home a week later post-procedure, and then when I was preparing for this, I just went back and looked at her stuff. A year and a half later, she's still alive. She is on full dose anticoagulation. She did have her nephrectomy, and so she's completely anephric and dialysis dependent, but otherwise doing well. Any questions?
We have time for one question.
Is there any concern with femoral central line that the thrombus?
Yes, yes. And it was literally lesser of 2 evils. Yeah, my partners and I in the ICU, I actually batted this question around. For those of you that didn't hear, the question was central line, femoral versus upper. I was more concerned about potentially having the wire end up inadvertently down in the RA, even with careful measuring. She was normal stature in a 16 centimeter line. I should be able to ideally mark. However, I was a little worried about that. Whereas I actually ended up placing a 16 centimeter femoral line as opposed to the normal 20 centimeter line. Yes, I mean, it's a 4 centimeter lesion. Your valve is not that big. So and that was why we had these conversations intra-op, because if that thrombus broke off and obstructed the valve, she's dead instantaneously. There is no embolectomy, like there was no backup plan for her, which again is why we had these hard conversations. It was almost a 2-hour pre-op conversation, having family there. And quite honestly, I mean, because she had kids, I had her bring all of her kids in, do hugs, kisses. I normally say, oh, do hugs, kisses, and see you laters. But they did hugs, kisses, and we'll hope to see you later, because I wasn't entirely sure she was going to survive the surgery. So.
Well, I'm glad that wasn't my case. Next is a complex case. entitled Titanium Hypersensitivity Following COVID-19 Infection. And we'll have the presenter come up and introduce themselves.
Well, howdy from Texas, everybody. My name is Elijah Pariso. I'm a third-year medical student at the Texas College of Osteopathic Medicine. And today I'm going to be talking about titanium hypersensitivity following COVID-19 infection. I co-authored this publication, or this presentation, with fellow med student Arnav, and this would not have come into play without Dr. Bailey Klassen. She's been a wonderful mentor these past few months. These are our disclosures of note. And for our learning objectives today, I'd really like to hone in on three things. The first being a review of the mechanism behind delayed hypersensitivity reactions. Two, the introduction of a potential cause of hypersensitivity reactions following COVID-19 infection, and that's where we'll be spending a bulk of our time today. The third is going to be a little short, but it's making awareness of screening tools that can help prevent reactions from occurring, might help change our management. But before I talk about our case, I think it's appropriate for us to step into the world of pain. And I'd like to provide a refresher or an introduction on intrathecal pumps. And these are pumps that are implanted and catheterized into the dura to provide direct access to spinal fluid for targeted pain management treatment. This is, the indication is typically going to be chronic low back pain, as was the case for our patient. And some pros that we can find in intrathecal pumps is that because they are inside the spine, one, we get targeted access. Two, we have continuous access. And three, because of this continuous access and the targeted access, there is less of a requirement for high-dose opioid use. Some cons of intrathecal pumps is that this is an invasive procedure, and with invasive procedure, there are risks of complications post-op. One of the ways that we can prevent these post-op complications is through the hardware that we use, such as titanium, which has been found to be more biocompatible compared to other metals and is pretty durable. But we would be remiss to neglect any of the issues that we face with titanium. The main ones being titanium toxicity, and this is from the wear and tear of this hardware over time. The second is going to be hypersensitivity, and this is where we will be spending most of our time. This presents as eczema or bone formation after implantation. Let's talk about our case. So we had a 70-year-old male coming into the pain clinic with a history of neck and back pain, followed by neck and back surgeries, history otherwise unremarkable. He presented to us for an intrathecal pump trial. His pain prior to presentation had been managed with high-dose oral opioids. Also of note, he had a very prolonged and very severe course of COVID-19 infection and was hospitalized for a couple weeks. And for those surgeries, they were cervical spine fusion as well as a spinal cord stimulator implant, both of which had titanium, and he tolerated those pretty well. So after the patient underwent a single-shot intrathecal trial that was successful, the decision was made to place a pump. Post-op in the weeks following is unremarkable, but 3 months afterwards, he presented with a rash overlying the intrathecal pump. He was referred to dermatology for contact dermatitis, and he was treated for with topical steroids at that time. After testing for allergies, he was found to have an allergy to polydioxazone sutures used to close the incision. 1 year post-op, the patient, the decision was made to relocate the pump with closure of the incisions with a less antigenic material. 3 months after that, the patient develops another rash. And follow-up with dermatology showed a response to titanium on skin allergy testing. So 5 months later, the pump was removed, the wound healed without any complication after that, and he continues to be managed on oral opioids. So what does this case tell us? This patient presents with new onset hypersensitivity to titanium and with otherwise unremarkable history, as well as previous toleration to titanium. The only difference that we see here really is this prolonged and severe course of COVID-19 infection. Now, I was trying to do some digging as to other cases where this happens, and the literature is pretty sparse. However, there are other cases regarding insulin and dermatological filler, basically. And all cases demonstrate resolution of symptoms with removal of this offending agent. Now, it would be terrible of me to not leave you with a proposed mechanism, and this is what we have so far. This is a potential mechanism that we can have to explain what happened to our patient, and involves a spike protein, which I'm sure you are all familiar with. The mechanism that is suggested is a binding to the ACE2 receptor, which leads a balance towards a more pro-inflammatory state, leading to granuloma formation and hypersensitivity. As I said before, the literature is still sparse in this case and other cases. But we can say this. This case brings to light potential sensitivity to various stimuli, specifically, in our case, titanium hardware following COVID-19 infection. And because most cases of titanium hypersensitivity are done retrospectively, it seems like our only diagnoses and treatment can be made post-op. There are screening tests that are available, such as patch testing and lymphocyte transformation, and I'll speak very briefly on these two, but patch testing involves placing a patch on the patient's skin. But with regards to titanium hypersensitivity allergy, it leads to variable results because titanium's percutaneous absorption is pretty low. Lymphocyte transformation has shown to be superior and is clinically validated. However, it's not FDA approved, and most insurances do not cover it, so that will always run a risk. So until then, it seems that patch testing is most utilized in clinics, but be on the lookout for more testing as time goes on. And here are my references. Thank you for your time.
Questions from the audience?
Sure, yeah, that's a great question. There are other implants available. I've read about zirconium implants. I've read about ceramic implants. Regarding this patient, though, I think after 2 trials, that was about it, you know. But yeah, some further literature seeing if we can switch to something else would be an interesting thought, for sure. The cervical fusion, yeah, that's really interesting because it was still... That is something that we still don't know. Yeah, the cervical fusion was titanium, and he tolerated that fine. But this allergy to titanium and no response in the cervical fusion it still has us scratching our heads.
Yeah, also, I mean, that was what I was going to say. If the device or whatever, and why didn't he respond to it once he started doing the response to the intrathecal pump? Why didn't it then cause a problem with the instrumentation in the neck? Is it so epithelialized that you wouldn't respond? And if the device cannot be removed, how do you mitigate what's going on?
Yeah, no, that's a really good question. So based on his previous treatment for the initial allergy to that suture, he had been treated with topical steroids, but I think at that point, topical steroids for a long period of time, he would not have wanted that. Too many side effects. But I'm sorry, can you repeat the question?
I mean, would you, if you can't get the device out, or if you did react to the cervical fusion, can you remove, I guess you can remove the hardware. What if it could not be totally removed? Is there, other than maintaining on steroids, I wouldn't know what to do for the person.
Yeah, I am not too sure about that.
The theory in discussing, especially with the allergists, is that, an immunologist, is that we do think his cervical hardware was so well healed and so well epithelialized because that was a surgery from long ago, and his COVID infection was more recent.
Thank you.
I think also looping back into the proposed mechanism, this idea of binding to ACE2 and leading to a more pro-inflammatory state, perhaps this newer foreign body led to this reaction.
Thank you so much. Our last complex case for this session is entitled Postoperative Hemodynamic Instability Following Adrenalectomy for Presumed Adrenocortical Carcinoma, Anesthetic Implications of a Rare Renal Cavernous Hemangioma. And presenters, come and introduce yourself and where you're from.
Hi, good afternoon. My name is Aryan. I am an OMS4 at LECOM.
And my name is Sebastian Merchant. I'm also an OMS4 at LECOM.
And today we're presenting on postoperative hemodynamic instability following adrenalectomy for presumed adrenocortical carcinoma, anesthetic implications of a rare renal cavernous hemangioma. So an adrenal cavernous hemangioma is a rare benign vascular tumor of the adrenal gland. Radiologically, they mimic malignant tumors like adrenocortical carcinoma or retroperitoneal sarcomas. And perioperative challenges include hemodynamic instability and significant intraoperative bleeding risks due to vascularity. And most cases are incidental findings, but usually greater than 10 centimeters when detected. So why this case is unique, one of the largest reported adrenal cavernous hemangiomas was our case, 17 centimeters big. The mass initially suspected to be an adrenocortical carcinoma due to imaging and size. Postoperative hypotension was misdiagnosed as bleeding, unnecessary re-exploration, increased risks, and then highlights POCUS utility for rapid hemodynamic assessment, and we'll discuss all of that in the ahead slides. And these are the learning objectives. These include review the diagnostic challenges of large adrenal masses, understanding perioperative management of vascular adrenal tumors, explore the role of POCUS in postoperative hypotension, identify anesthetic risks and lesions or lessons learned, and apply key findings to similar high-risk surgical cases. So patient overview, our patient was a 77-year-old male with well-controlled hypertension who presented with weeks of vague right upper quadrant discomfort, no weight loss, flushing, palpitations, or signs of hormonal excess. There was no significant cardiac history, and imaging was initiated due to abdominal discomfort. On initial assessment, physical exam was only showed nonspecific abdominal tenderness. There was no signs of endocrine symptoms, including Cushing's or hyperaldosteronism. And initially, we suspected an adrenocortical carcinoma or retroperitoneal sarcoma. Preoperative labs included a normal CBC, electrolytes, and endocrine profile.
Yeah, so the reason we were suspecting an ACC off the get-go is, just due to the size of it. Usually in an ACC, you're going to see hormonal changes. That's why we worked them up for endocrine dysfunction like Cushing's and hyperaldosteronism, but everything came back negative. So then we thought, this tumor could have malignancy in nature. And so that's what led us to have a differential with the retroperitoneal sarcoma as well. Things like leiosarcomas and leiomyosarcomas in that area, pushing from posteriorly on the adrenal gland anteriorly, just due to the size. 17 centimeters was a pretty big diameter. As you can see here, this is across the board at 17 here, and it's pretty big. But his only complaint, which was surprising to us, was that he was just having right upper quadrant abdominal pain. So that's kind of what led us to think, more so malignancy, and it was displacing the anatomy in the area. We initially did an ultrasound, and then it led us to do a CT and to an MRI. And if you look, you can see a heterogeneous mass arising in the right upper quadrant, and you can see peripheral enhancement. So now our concern was if there's vascular invasion. Obviously, we also did an MRI to make sure, and we noticed that there's no vascular invasion, no metastasis in the area. So it kind of led us to now think of anesthetic and surgical management. Obviously, in this case, we're going to do an en bloc adrenalectomy with a midline laparotomy. So that's kind of how they proceeded in this case. So as we talked about, we're thinking it's a malignancy, and here's our differential. We went on with the adrenalectomy. These were the labs that were all pretty normal from before the procedure. And usually the guideline is, if you have suspicion for malignancy as well as greater than a diameter of 6 centimeters, you're going to proceed to surgery if the patient has complaints. So in this case, obviously, there was a vascular issue, in the area because due to the nature of, the location as well as the size. And as we talked about, they proceeded with the en bloc resection. They had, blood transfused, matched, everything ready to go. And they were prepared to convert it to extended resection as well as vascular repair, depending on how the surgery proceeded. So this was a little bit of planning from the preoperative team. They decided to use general anesthesia as well as a thoracic epidural catheter for post-op pain because they were expecting significant post-op pain for this patient. And they had IV fluids ready to go, crystalloids, and blood because they were expecting as well rapid blood loss due to the arterial area. And just keeping in mind that he's 77, has well-controlled hypertension, we had 2 units of blood ready to go for him. And that's what they ended up transfusing during the procedure. I believe the estimated blood loss was around 800 milliliters. So we did talk about the intraoperative course already. We had a bunch of ligation for the small feeding vessels in the area. There was marked hypervascularity. And they proceeded with the appendectomy. They had adrenalectomy, and they also had an incidental appendectomy due to seeing, fibrosed tethered appendix. So they wanted to remove that as well just for safety. So they transfused 2 units of blood. We had 800 EBL, and then he was started on a continuous norepinephrine drip to maintain a MAP of about 65 to 70, keep it above that during the tumor manipulation. And we had the balanced crystalloids as well. This was the gross specimen when resected. As you can see, it's pretty large. It was encapsulated. There was areas of infarction inside. And surprisingly enough, when it was sent to histopathology afterwards, it was confirmed to be a renal cavernous hemangioma. And those are pretty rare. I believe since 1955, we've only seen 67 of these. It wasn't surprising that it was misdiagnosed just because of the rarity to it. And it's hard to diagnose a cavernous hemangioma until you have histopathology. So, you had to resect it anyway. It was the right thing to do. But the problem arose was in the post-op period, whenever 30 minutes later he had refractory hypotension and he had lactates of 4.0. And as we know based on literature, if you have lactates of 4 or above, it's representing poor prognosis, and it's a higher chance of morbidity in the post-op period, even though he had stable hemoglobin. So now he was transferred to the PACU and intubated, and he was on the norepinephrine drip, but he was still within 30 minutes refractory hypotensive. And in the PACU, we just kept him on the infusion, but now they were worried that his lactate's high, he's a 4, he's got low continuous blood pressures of 85/50. We're on pressors already. What do we do? Do we take him back to the OR? Do we open him up? They were very concerned about intra-abdominal hemorrhage. There was a lot of arterial ligation in the area. Could we have nicked, any vessel? So it was, and he's old, and we're worried about, morbidity. So they decided to take in what their eyes was the best, course of action. And they also administered anesthesia. They're thinking, this could also have played to the long-term hypotension afterwards. So these were the indications that they had for re-exploration. They ultimately did decide to take him right back to the OR and open him back up. Due to their raised suspicion for ongoing internal bleeding, as well as elevated lactate of 4, and the persistent hypotension due to even with refractory, vasopressors, they said, let's open him up. But on findings, they found no active bleeding. All the ligatures and vascular contact sites were intact. There was only moderate blood-tinged acidic fluid, and there was no hematomas or intraarterial hemorrhage. Ultimately, they just re-irrigated the cavity, closed the incision with hemostasis again, and then he was transferred to the ICU for post-op stabilization. But as you can tell, this is a problem because we took him back, opened him up, and there was nothing wrong, and that poses a lot of risk. Taking a patient back, obviously, when he came back out of his second procedure, he was hypothermic. Hypothermic can also increase your risk of coagulopathy. It can cause low blood pressures, and opening him up a second time is going to increase your risk of death in an old patient and increase his stay in the ICU. It costs money. You have to re-sterilize. There's risk for wound infection. And there's just a lot of complications with opening someone up, which we probably shouldn't have done in hindsight. In the ICU, he recovered pretty well. His hemodynamics improved over 18 hours, extubated post-op day 1, and he was transferred to the floors post-op day 3, discharged home in a week. And I think, it took longer due to that. It took longer because we reopened him. So as we already talked about the final pathology, we showed you the gross image, and the appendix contained benign serrated polyps. So basically, this was a pretty benign imaging for him and specimen for him. Likely causes of the post-op hypotension is what I wanted to discuss because he was not hemorrhagic. That's what we were thinking. And we should have kept in mind that, yes, he has well-controlled hypertension before the procedure, but
he could have a degree of diastolic dysfunction in an elderly patient. Histopathology showed us that it was hemangioma, so taking that out, could have easily caused the hypotension post-op, and which ultimately led to our unnecessary re-exploration. But this was the role of POCUS. I think POCUS is more up and coming now. This is where we want to discuss that POCUS would have been extremely valuable in this case, whether it was preoperative or post-op. We could have done a quick cardiac fast exam to look at his ventricles. His left ventricle probably would have been thickened, hypertrophied, and we would have seen a degree of diastolic dysfunction causing hypotension in the long run. We could have planned the surgery better in the sense that we would use different, anesthetic agents, but we would also increase his fluids, and we would also kind of raise his blood pressure before we started manipulating the tumor and taking it out, because we know that his blood pressure is going to drop afterwards. He's got a degree of diastolic dysfunction. So, pre-op and post-op, a 3-minute ultrasound could have easily helped us navigate, this problem that we faced. Also, if we did a quick post-op, we would have seen, again, a collapsible IVC. We would have seen that it's an elderly patient. He was probably, dehydrated going into the procedure due to the bowel prep and due to the fluids and not eating. So that, we would have had a different outcome and approach in this procedure. This is just a couple images of how you can cluster and phenotype the cardiac, left ventricle, right atrium, left atrium. You can just phenotype it and cluster it into different, organizations, so you can tell, is it biatrial dilation, biventricular dilation, if it's just left ventricular problems, and that would guide your management. And this next slide is showing how your management could have been guided. Cluster 1, you're mostly thinking that he's fluid underloaded, and you can give him norepinephrine, vasopressors, and phenylephrine to kind of monitor post-op or during. And then the other, cluster 2 and 3, you're going to see overload. And so you would monitor that differently. But these were the key takeaways. I think, the use of POCUS could have been very beneficial in this situation. It would have given us more comfort and less desire to quickly open him up and trust that we can continue him on conservative management with fluids, vasopressors, and keeping him for an extra couple of days. But rather than put him through the risk and the higher chances of morbidity, we could have given him hydrocortisone stress dose. We could have maybe used albumin to try and combat the third spacing. But there was multiple things that we could have done in the situation to prevent hypotension. And yeah, that's what I just wanted to highlight with POCUS. But that's ultimately, this is some literature supporting POCUS, and here are our references, and thank you for your time.
Thank you very much. We're a little bit over time. If you have one question that's short, you can go ahead and do it.
I would just suggest that a POCUS here might not have given you all the information you think it would, given hypovolemia, bleeding, distributive shock. It all look very similar, right? I'm a little curious, this patient went to PACU intubated on pressors. Was that because the surgical ICU bed was not available? Or is there some other reason to go to the post-operative recovery area first?
So I think their plan was to keep him there for a little bit and monitor him to see if the necessity for ICU placement arose. But I think ultimately seeing how he proceeded with the drips and his outcomes, they decided to take him back.
Also telling they went back quickly. I often have to fight the surgeons even does.
Yeah, I think the size of it definitely must have played a role.
Very much. All right, this concludes this session. Thank you, presenters. You all did a fantastic job. Audience, I hope that you guys voted for your favorites here. Thanks for all your good questions. The awards are going to be decided and given out at the conclave tonight. There's going to be an award for the best one with the complex cases, and for the scientific investigations. Only medical students, residents, and fellows are eligible for the award, even though they were all fantastic. So thank you so much for your attention.